Hi, in this video I'm going to go over questions that were submitted for part 2 of the fatigue and pain course that I wasn't able to answer during the course Q&A. Okay, first question. Would SpectraCell lab testing be a better alternative to OAM, organic acids testing, I assume, seeing inside the cell? I think they're, from what I understand of SpectraCell tests, they're looking at RBC micronutrients. Organic acid tests are looking at surrogate metabolites, so I think they're completely different tests altogether. Seeing inside the cell, I don't think anything is really going to be able to see inside the cell. They're all surrogate markers to have an assessment what's happening on. But like a red blood cell nutrient analysis is totally different than organic acids testing. So there isn't one that's better. It really depends on what you're trying to look at. Next question. How do you improve heat shock proteins? How long does it last? I don't really know of any way to improve heat shock proteins. I would just assume heat shock proteins would be efficient if the immune system is healthy, so I would just think of general immune support, but I'm not aware of any ways to specifically impact heat shock proteins. Next question. Is an IV of NAD worth the cost of $220 for aging people? That's how do you even possibly answer this question? Depends on the person, depends on their outcome and response to it. NAD does have NAD has some interesting early research that it may have some significant impact on churning on sirtuin genes and helping with AMPK pathways. Most of that has been done with animals. There aren't any human trials that I'm aware of. There surely aren't any human trials on IV NAD. So the physiological potential is there. I don't have experience using IV NAD. So again, I don't know. And as far as cost goes, everyone's going to have their own cost-benefit ratio to calculate. Okay, is there a test to check for mitochondrial autoimmunity? There's actually mitochondrial autoantibodies that can be tested. They're just not available commercially. You can do them in the laboratory, but that's one of the drawbacks. There's lots of autoantibodies that are available as a researcher to check for, but there isn't a bunch of healthcare practitioners throughout the world going, I want to check mitochondrial antibodies, and there's labs going, there's a huge market for this. So that's the unfortunate thing with many autoimmune target protein markers, even a lot of the autonomic nervous system autoimmune target protein markers we talk about in the course, that studies have been done with ME/CFS patients. They're not available. They're in a commercial setting where a practitioner can just order them, but they're just done in research circles. So it's one of the unfortunate things, but I'm not aware of any lab that is doing commercial mitochondrial antibodies. Next question. If we see a client who went into early menopause, should we consider mitochondrial impairment? There's some degree of mitochondrial impairment with anyone that has any kind of chronic illness. I would assume that your main mechanism for early menopause was just mitochondrial inefficiency. However, the more mitochondrial insufficiency a person had, the more likely, if they had other factors that can lead to early menopause, that would happen faster. So you wouldn't jump into early menopause as mitochondrial impairment as the only factor, the only variable. But it probably has a role to play, just like it has with any kind of early disease development or early impairment of the mechanisms involved with the condition. Okay, next question. In dealing with ME/CFS patients or chronic fatigue patients who have crashes triggered by mold, do you have any advice on what they can do before entering buildings that almost always have mold, such as schools and large office buildings? So this sounds like they actually have IgE mold allergy, not just sensitivity. And always high antioxidant support would be critical. But these are the cases where low-dose antigen therapy by an allergist can be helpful for some patients. Some patients do low-dose antigen therapy for mold that has no effect with them. But it's one of the things you would definitely consider when someone has clear IgE reactive allergy, because at that point their immune system is going to have a severe inflammatory immunoglobulin mast cell response just by exposure of mold. Okay, next question. Is the Warburg effect acquired or inherited? It's acquired. So we don't know why. We know, like in cancer patients, this is very common for some of the immunological changes that take place by impacting that pyruvate dehydrogenase enzyme, which are mostly immune-related cytokines, immunokines that impact it. But it is an acquired mechanism. Can you have a pathogen issue that does not show up on antibody tests? Yes, for sure. So then doing a GI map test would be the next step. Well, again, not necessarily. So there's just pathogens, especially different viruses, that just don't show up with the antibody testing. If the GI map is the next test, it really determines. You'll have to decide as a clinician if you really suspect there's something like a GI pathogen that's there. So many GI pathogens are definitely not going to show up on a serum test. So if you were looking for a pathogen and you couldn't find anything in serum, it's just possible you didn't check enough things. And the stuff that's really going to show up on serum is going to be like systemic bacterial infection, viral reactions, but then parasites and pathogenic bacteria in the gut are never going to show up on a blood, or rarely going to show up on a blood antibody test unless they breach the barriers and get into systemic circulation. So yeah, I mean, if your goal is to just search for pathogens and you exhausted your antibody serum testing, then maybe as part of your workup you do look at the GI map. Next question. If you see a drop in cholesterol in one lab but see it back to normal in a follow-up, even within a month or two, is that still indication of a red flag? No. So one of the red flags is a sudden drop of cholesterol, and the closer the time periods are, the more diagnostic it is. So if someone had a cholesterol number that suddenly dropped a year ago and now they're back to normal, that's not the same thing as a cholesterol drop that happened within the past 2 weeks. That's where you have a red flag. Now, when you see a sudden drop of cholesterol, you want to look for other red flags as well. Is their albumin level drop? Is their white blood cell levels low? Are the lymphocytes low? Is there a pattern of active infection? Are there acute phase reactants up? So you don't want to just look at that drop in cholesterol. And when we say drop in cholesterol, we don't mean like it went from 200 to 180. We're talking about it went from like 200 to 75. It's pretty significant drops that you'll see. So it's more than, let's say, 20% for sure of a drop. That's significant. In the shorter the time period, the more diagnostic it is, but in and of itself, you have to look at other lab markers, like I mentioned, to consider it really being a red flag or not. Okay, next question. Can people respond negatively to glutathione supplements? All the time. There's just some people who cannot tolerate sulfur, glutathione being a sulfur-based compound. So in those cases, yeah, you're not able to have them take glutathione. And then you have to just try to use other antioxidants to get the best effect. Is the skin test sufficient for measuring IgE reactions? Well, the skin test has very poor reproducibility, significant issues with sensitivity and specificity, but allergists, especially old school, love to run it. Some really feel they can catch things that the blood test may miss, but it's not a very reliable, reproducible test when different practitioners are doing it on the same patient. However, if you see a clear antigenic response with dispersion on the skin, it's pretty hard to dispute that. So, I mean, these are the intricacies of people that do it, but I think you're gonna be able to get a lot more of serum IgE testing for most people, and other times skin test is sometimes the way they found it because the IgE testing wasn't very reliable or properly done, and other variables that impact the IgE that are not clear. But it's going to depend on the preference. But for the most part, it's not the best test. And you may so if you have a positive response, let's just say, then that's great. But you can definitely miss many things with the skin test. So when you look at the false positivity and false negativity rates, it could be an issue. Since mitochondria use reactive oxygen species levels as a feedback mechanism, can giving high-dose antioxidants such as liposomal vitamin C interfere with mitochondrial activity? I don't. It would be an extreme amount of antioxidants that would completely shut down mitochondrial immune function responses. So I really doubt antioxidants are going to completely impair that or even have any significant impact on mitochondrial's normal response there. We're supposed to have lots of antioxidants in our system. Healthy people have really high levels of antioxidant activity. Chronic disease patients clearly do not, and whatever you give them may not even touch with the levels that they may need. So I wouldn't worry about any kind of antioxidant interfering with that. Next question: what role do you feel that mitochondria, antibodies, and autoimmunity play in mitochondrial dysfunction? What role do you feel that mitochondrial DNA is released by activating mast cells in the GI plays in the mitochondrial GI inflammation connection? Well, I think in part one we talked about mitochondrial antibodies. I think it plays a significant role in many autoimmune diseases, especially those that cannot recover. And it may be a key variable in why some chronic autoimmune disease patients cannot recover is because their immune system has impacts on mitochondria. But then the other issue also is just because they have mitochondrial antibodies doesn't necessarily mean that the antibody can actually get into the cell, because the molecular weight of antibodies crossing into the mitochondria will depend on the so-called leakiness of the cell membrane itself that allows for those antibodies to enter. So some people have mitochondrial antibodies and their cell membranes are healthy and the antibody never gets in there. Other people have cellular permeability issues, and those mitochondrial antibody can be severely destructive. So that's an area of research I would love to see people investigate. And then what role do you feel that mitochondrial DNA is released by activated mast cells in the GI plays in the mitochondrial GI inflammation connection? So that this is a good question, because yes, once the mitochondria is out of the cell from tissue inflammation destruction, that's where those autoantibodies could play a role. So I don't know what that role is, but I would suspect that it's a key factor in some chronic unresponsive patients. Would cryotherapy or cold showers be appropriate therapy for people with cold hands and feet? Absolutely. This is what you want to do. When people have really cold hands and feet, they have poor circulation. So cryotherapy, cold showers, they activate growth factors, and they activate vascular endothelium growth factors and endothelial nitric oxide, which help with circulation and blood flow. So it's really one of the most important things to do with people that have poor circulation. Next question. How can one train themselves not to get sleepy sitting in the sun? How can one train themselves not to get sleepy sitting in the sun? I don't know. Question. Can you comment more on hyperadrenergic POTS or dysautonomia treatments in general? Is the approach similar to CFS pain syndromes of just maximizing mitochondrial function? No, it's more complicated than that. Well, I'll just say this. Everything that we talked about applies to people that have POTS or dysautonomia treatments, because you have to improve their mitochondria, especially their brain mitochondria. But basically when they're having POTS, where they have this autonomic dysfunction as they change positions, you're looking at a lot of different neurological pathways. Some involve like cerebellar projunctions into the brainstem vestibular area. Some involve the parietal insular vestibular cortex. Some are directly related to injury and active injury to the actual autonomic centers of the brain. So it's as far as I can comment, it's not simple. Certainly something that's hard to answer without the individual case itself. And if you are able to improve the mitochondria and then develop plasticity in the pathways that are impacting their dysautonomia, they definitely can be improved. Next question. By what mechanism does acupuncture work? Well, when you just speak about the neurology of it, there's definitely numerous studies looking at functional MRI changes with acupuncture. So, unrelated to the energetic mechanisms of acupuncture, which is not my area of expertise, so I can't comment on those. But there are definitely studies with functional MRIs where they actually see major areas of the brain, especially areas of like the insular cortex, light up. Areas of the brain like the nucleus accumbens where opioids are released with acupuncture therapy. So there's no question acupuncture has an effect on the brain. And but the question is, are there certain specific points that make a difference between one or another? In all the studies they've done, they just see that nociceptive stimulation has an effect, and it can be used for analgesic effects and processing pain disorders. So for people that have chronic pain, it may be something that can be very effective for them to help them. And maybe over a period of multiple treatments, it can help develop some plasticity in the brain. But I'm not aware of that kind of research. I'm only aware of functional MRI changes. Do we need to avoid all pro-inflammatory foods, even when properly done testing by Cyrex shows we're not sensitive to all of them? I think this is a personal question. Do we need to avoid all pro-inflammatory foods? Again, I don't know what your clinical goals are, what your personal goals are, what your... So technically, you want to have a diverse diet. You want to have some pro-inflammatory food in your diet as well. You want to have foods that increase pro-inflammatory prostaglandins, because pro-inflammatory prostaglandins are necessary for normal healing and regeneration of tissue, even gut lining tissue. So a completely anti-inflammatory diet may not be the best thing. We want to have both pro and anti-inflammatory. You just want to have a higher amount of anti-inflammatory than pro-inflammatory. And as far as Cyrex testing no sensitivity, that's just looking for immune sensitivity that's unrelated to the inflammatory response in general. So the inflammatory response isn't all antibody generated. So there's T cell responses, there's macrophage responses to pro-inflammatory foods, and those are going to happen unrelated to antibody, which are B cell responses to food proteins. So a negative test for food sensitivity doesn't mean everything's okay. It just means you're not having immunological B cell responses to food proteins. Are there strategies to deal with increased symptoms caused by neurogenic inflammation following emotional stress? The more autonomic activity you have, the more sympathetic response you have, the greater neurogenic inflammation expresses. So, as far as specific strategies, reduce autonomic sympathetic load best you can. And whether that would be exercise or meditation or breathing exercises, anything that can dampen the sympathetic and activate parasympathetics would be ideal. Emotional relationships, physical contact, those would be the things to consider with neurogenic inflammatory causes. Next question. Since diet and lifestyle changes cannot impact genetic inherited diseases, can peptides bypass the genetic disease to create direct support? No. And listen, diet, lifestyle has some impact on improving health. It's just not going to reverse the disease process. So just because someone has an inherited disease, they still may have hypoglycemia that impacts their energy levels. They still may have reaction to food that causes rashes and all the other things. It's just that you wouldn't expect someone who has like an inherited demyelinative disease or inherited muscle atrophy disease that you're going to go in there and reverse. But you could still use diet and lifestyle to impact their phenotype to improve their health. You just don't want to get into a clinical situation where you think you're going to reverse these genetic diseases with that. You still can improve function and potentially change the expression of it. For example, I have a patient with Charcot-Marie Tooth disease. Can creatine plus exercise positively impact muscle mass? Yes. So the Charcot-Marie Tooth disease, which is a muscle atrophy disease, genetic muscle atrophy disease, muscular dystrophy, they've actually shown in studies where creatine and exercise do help with energy and muscle function. So again, they're not reversing their Charcot-Marie Tooth disease genetic expression. They're just using interventions that improve the functions they have. So that's important to consider. Okay. Will long-term use of SSRIs exacerbate or amplify the perception of chronic pain? Not that I'm aware of. As a matter of fact, most of the studies on selective serotonin reuptake inhibitors have actually decreased pain. And if you, but they work for a short period of time, and after a period of time they don't work. But if you remember that descending pain inhibition pathway, where you get central activation of the periaqueductal gray and the mesencephalon, that periaqueductal gray then inhibits the posterior horn where nociception inputs are coming in, and that's a serotonergic pathway. So what they actually find is that when they increase serotonergic pathway, that increases the impact of the pain inhibition pathways from the brain down to the spinal cord. And that's different than opioids. So opioids have actually been shown to increase brain sensitization. They actually make the brain perceive pain with chronic use more and more. So SSRIs seem to work for some patients for pain, but for a window of time, then they stop working. But they don't seem to cause sensitization. Opioids reduce pain, especially in the early stages with the dose they use, but if they're used chronically, then that leads to pain sensitization, and then the receptors stop responding to the opioid and they have to take more and more and more, and they get into that vicious cycle. So that's where SSRIs fit in compared to opioids. Next question. What are the challenges with nutritional absorption of nutrients with someone who has had gastric bypass? Would pain syndromes be more challenging to manage because of the bypass? So it really depends on the extent of their gastric bypass and how much microvilli are there. Some for sure will need to do IV nutraceuticals to improve their health. And this is where, for example, a red blood cell micronutrient analysis test can be very useful. And if the red blood cell micronutrient test is showing deficiencies, then IV nutrition would definitely be something to consider. A lot of people that have bypass still have some absorptive abilities, so you have to really evaluate their nutraceutical status to determine that. Next question. Can hyperbaric oxygen therapy be used for chronic fatigue and pain? What is HPOT's effect on mitochondria? So hyperbaric oxygen therapy should be considered with fatigue and pain, especially neurological based fatigue and pain, and I should say even any injury, but we're talking about chronic pain here. So the way hyperbaric oxygen works is just basically, the easy way to think about it is that it pushes oxygen deep into the tissue, so it makes more bioavailable oxygen for the mitochondria. So it could be useful, but I think if you can increase more mitochondria and improve mitophagy and optimize fusion and fission through all the different mechanisms, it's going to be much more effective than hyperbaric oxygen. And if you have mitochondria that are totally uncoupled and not healthy, if you increase their oxygen load, they may produce more reactive oxygen species, and the person could actually feel dramatically worse after hyperbaric oxygen therapy. So remember, when oxygen gets pushed into cells, like mitochondria and tissues, they're going to produce some reactive oxygen species, which then uncouple itself and injure itself. So if they don't have healthy antioxidant status, and they really push oxygen into mitochondria, they may feel much worse. So be aware of that. Can the new Cyrix lymphocyte map test help decipher inflammatory cytokines from immune cells? No. The Cyrix lymphocyte map test is basically looking at populations of T cells and B cells. And it's not really looking at inflammatory cytokines themselves. So we're looking at helpers, T suppressors, percentage of helper suppressors, and so forth. But it's not going to help decipher inflammatory cytokines. You will need a cytokine stimulated test for that. And hopefully they'll have one of those in the near future. If someone gets pain with exercise, what is the ideal time of giving them antioxidants to dampen this? So, everyone's going to have some pain with exercise. We're just talking about severe inflammation, fatigue, and inability to recover. So you really want to consider both before and after exercise. Those would be the ideal timings for antioxidants. Can you comment on COMT and quercetin use? COMT, catechol-methyltransferase, is an enzyme that's used to clear out things like estrogens, things like serotonin, catecholamines. It's a methylation pathway. There's some studies that have been done in vitro that shows that it may inhibit COMT. You got to be very careful looking at in vitro studies. Like in vitro studies, you're looking at one enzyme with no other variables in a test tube, and it's suppressing it. So I wouldn't have any hesitation using quercetin when people have COMT issues, for the most part, unless there was someone who had, for example, estrogen positive breast cancer and they're dealing with breast cancer and they really have high levels of estrogens. Maybe quercetin may have an impact on that, but it's hard to say from an in vitro study. But since the stakes are so high, I wouldn't use quercetin in a scenario like that. But I think for everyone else, I really wouldn't think that quercetin is a significant enough COMT inhibitor where you would never use it. And quercetin is a very powerful natural anti-inflammatory, antihistamine compound. So I wouldn't want to just avoid it for the most part. So I think it would depend on the condition and the stakes, but don't jump into the fact that in vitro studies show that quercetin can dampen COMT, so it's going to happen that way in the body. That's not how in vitro studies. You can't translate in vitro studies to what actually happens in human bodies, but it does give you a clue for further research. What are your thoughts on pulsed electromagnetic fields for chronic pain? What about Violite for the brain? So for sure, pulsed PMFs have some good studies published on it for helping with chronic pain. So that could be something for chronic patients to consider. In the course, we really just focused on the functional medicine, systemics biology approach to chronic pain. But there are lots of different therapies that have a promise for chronic pain, like pulsed EMFs. And Violite, I don't have any experience with, so I can't comment. But other people just look and see what's published on it and see what other people say. I don't have any experience with it specifically. What's your opinion on months of antibiotic Lyme treatments in patients with chronic pain? Well, it depends. For some people, it could be very significant. For other people, it's just they get into the Lyme world and they get overtreated with antibiotics, and then they may even have Lyme's disease, and the antibiotics can uncouple their mitochondria and totally wipe out their healthy gut microbiome and has negative effects. It's very, very common to be misdiagnosed with Lyme disease because many people hallucinate lab tests that are also inaccurate and try to blame everything on it, and they get stuck in this pattern. But in other cases, like someone has a visible tick and they have a bullseye rash and symptoms happen right away, so it's very clear you don't even need testing to consider that possibility, and it may be appropriate therapy for them. So I think it's gonna really depend upon the situation. You talked about the oats test. Oh, okay. So I didn't understand the oats test from the previous questions, I think in part 1, but I'm assuming oats is the organic acids test. Okay. So you talked about I would assume oats being organic acid test and melatonin, but to what extent do neurotransmitter imbalances such as with GABA and serotonin impact MCFS and chronic pain? How do you deal with this? First of all, you can't really measure neurotransmitters that are happening in the brain with urine testing or blood testing. Even CSF testing isn't going to clearly show the amount of neurotransmitters in a tissue. So I can tell you, as someone who's worked a lot with nutraceuticals and brain and neurotransmitters, you don't get much of an effect at all with playing with natural serotonin, GABA, catecholamine nutraceuticals for ME/CFS. And melatonin's a whole different story. Melatonin's a hormone. I mean, there's clear changes in metabolic effects with ME/CFS with melatonin at nighttime. So that's I would say I have played a lot with neurotransmitter support in my years of practice for chronic pain MCFS. It doesn't get you far for those patterns, but if someone has anxiety and you want to, or has sleep issues, you want to activate that GABA receptors, that could be effective. If someone has sleep issues, raising their serotonin levels can be somewhat effective, but it plays part of the multiple mechanisms involved with ME/CFS. But it's not going to be like the game changer. So maybe it'll help with their sleep, maybe help with their anxiety, things that are involved with it. But with ME/CFS, you're going to have to go through all the different mechanisms that we talked about. Okay, with Nico's case, why would the IV vitamins and poly-MVA, which is a IV nutraceutical mixture, make him worse and cause the reactions they did? So I don't know. I thought about this, and I really couldn't understand why that mechanism took place. You can make a lot of theories, but as with all chronic patients, they have some very unique characteristics that are hard to figure out. And for most people, that would not happen. So I don't know what the specific mechanisms were. What are the best methods in assessing long-term average status of micronutrients, catecholamines, and neurotransmitters? So for micronutrients, it's going to be a red blood cell test where they look at micronutrients within the red blood cell. For certain micronutrients like B12, things like methylmalonic acid, which is a byproduct of proper B12 usage, that can be useful. So they have those kind of markers. Catecholamines, you can measure some catecholamines in urine, but those are urinary. Don't confuse catecholamine, like urinary tests for catecholamines and neurotransmitters, as anything having to do with what's in the brain. Catecholamine measurements and neurotransmitter measurements in a urine test, for example, or reflection of gut cells that are making neurotransmitters, and of liver and kidney cells that make neurotransmitters, and how those are cleared. So, these labs that do urinary neurotransmitter testing, in my opinion, are completely fraudulent when they make these associations with, like, this is the levels you're measuring in the brain. And that's all I want to say. Are there any ways for patients to regularly measure cerebral hypoxia at home? Well, you could do you can get a tissue perfusion device to give you some clues. You can look at a pulse ox to give you some advice, some mechanisms there. Those are the main ways to see what's happening with the tissues and with the SBOT calculations that are done. If a person's circadian rhythm is really off due to erratic sleeping and eating patterns for years, how long after adopting a consistent routine will they see benefits? Everyone's different. Like, some people's circadian rhythms will come back within a week. Some people's may not come back for months. But you should slowly start to see some change over time if they're eating a consistent pattern. I say most people are gonna respond within weeks compared to months with getting the circadian rhythms back. Next question. How does radiation impair the process of bioenergetics, especially in those who are weaker immune compromised? Radiation produces oxidative stress, so free radicals. Free radicals then destroy the mitochondria. Initially, free radicals will deplete glutathione antioxidants in the body, and then once those are depleted, then they'll start to amplify oxidative stress. The bioenergetic process of making ATP is going to produce free radicals, and that's amplified by radiation. You can have much more compromise. Number 36. For those with fatigue and pain syndromes, what kind of infrared sauna, red light device, or other lighter massage machines have you seen show bioenergetic improvements? Well, there's definitely some individual uniqueness responses to various devices and treatments. I'm not a machine expert, so I would just say it's all over the place. Like, when you see patients tell you what they responded to and didn't respond to and try different things, it's so varied and unique from one patient to the other that there's no, I can't tell you one clear thing that, for sure you should know about this. Next question. Is there a way to measure what is going on with insulin over time? how do you differentiate between an energy drop from insulin surge versus something else such as food allergies and someone with an HbA1c of 4.8? So the interesting thing is they're getting implanted biomonitoring devices that measure insulin and glucose all throughout the day. That's an area of growing research, and that might be something that gets used more and more to monitor chronic blood sugar issues. So that would be a implanted biomonitoring insulin and glucose device. I'm not sure where you would even get those outside of research circles. And then how do you differentiate between an energy drop from insulin surge or something else such as food allergies? Sometimes you really can't. Sometimes, if you look at the content of the food and it's like low glycemic index and it causes a reaction, it's probably not an insulin surge unless they had so much of it. And then if it's food allergy or food sensitivity, if it's food allergy, you should also notice immediate inflammation or skin reactions or mucus production, have to clear the throat or things like that. That could be some clues that it's more of a allergy. If it's a food sensitivity, you may not really know. So I would say you would just look at the amount of glycemic challenge it has to the person. And if the glycemic challenge is not really the factor, then you would not consider that. HbA1c is really for long-term blood sugar glycation. That's not going to be really an indication of an insulin surge from foods. HbA1c is a marker for 6 to 8 weeks of glycation on hemoglobin. So the HbA1c is irrelevant in a scenario like that. There's been so much written lately about the benefits of CO2 and taping the mouth, breathing through the nose, yet with Nico he used oxygen at the beginning. With breathing have helped him improve oxygenation. What are your thoughts and cautions about these approaches? Every patient's unique. Some people can't handle taping because it causes anxiety with them. Some people don't have enough healthy nasal respiration because of a deviated septum. Like someone like Nico, who, if you look at the physical exam, we noticed he had a deviated septum and his sinuses were totally congested. If you tape his mouth, he's not going to be able to function. So anyone that has anything impacting their oxygen, like deviated nasal septums or really congested sinuses, are going to have a really hard time with taping. So we didn't use that with him. And he already had an oxygen device, so when he was exercising, I had him use his oxygen device with exercise. Oxygen, there's lots of different equipment out there that can be very expensive, where people get these like CPAPs, where they breathe with that are designed for exercise, with a bike that measures their activity and their respiration, or simple just oxygen concentrator that people get, which is use water that isn't 100% oxygen but 60-70% with exercise. That can be useful as well. So it's just a field of exercise with oxygen to help people be able to work out longer and have greater oxygen going to their cells and tissues to help build greater length of exercise, and greater length of exercise means greater mitochondria. Okay. I hope I answered your questions. Thank you for submitting them and for taking the course. And I really appreciate everyone's participation. Thank you so much.